Hi friends, in today's video we're going to be talking about liver cirrhosis, and if you like this video make sure to give it a thumbs up and subscribe to the channel. We make new videos every week for pre-nursing students, nursing students, and nurses. There's also some free resources listed down below as well as an NCLEX study guide, but let's get into it. Alright, so liver cirrhosis. So it's a chronic hepatic disease characterized by diffuse destruction of fibrotic regeneration of hepatic cells. It alters liver function and normal vasculature, impairs blood flow and lymph flow, and causes hepatic insufficiency. So there's a few different types of liver cirrhosis. So the first is NCLEX cirrhosis. This is the most common type. It occurs 30 to 50% of the time in cirrhosis patients, and 90% of those patients have a history of alcoholism. There's biliary cirrhosis, and this results from an injury or an obstruction. There's post-necrotic cirrhosis, which comes from different types of hepatitis. There's pigment cirrhosis, which results from disorders such as hemochromatosis. There's cardiac cirrhosis, which comes from right-sided heart failure. And there's idiopathic cirrhosis, which has no known cause. All right, so this is the overview, a very quick overview of the pathophysiology. This is kind of a simple form. So you have necrosis of the liver cells, which leads to scar tissue, which is going to lead to fibrosis and alterations within the liver structure and normal vasculature, impairing blood flow and lymph flow, and ultimately causing hepatic insufficiency. So this is a more in-depth pathophysiology chart, but I really like including these charts because I think you guys can print them out, take a screenshot, print them out after, and it kind of gives you a nice overview of the pathophysiology of liver cirrhosis. At the very top, we can see the different causes. So we have infections such as hepatitis, we have autoimmune disorders, different toxins like alcohol, metabolic disorders, and genetic disorders. And if you look over on the left side, you can see notes on abbreviations, so you can see what all those different types of things are as far as the letters in like the genetic disorders and the autoimmune disorders. You don't need to have all of these memorized. They're probably not going to pop up on your nursing exam, but you should know that the nursing interventions and things you would do for patients with liver cirrhosis and just the things that would maybe cause that. We can see we have all these different causes, which causes death of the hepatocytes, inflammation, destruction of normal hepatic structure, which causes scarring and fibrosis. And there's some more information there you can read if you want, but I'm not going to spend too much time in this chart, but that leads to cirrhosis. And then you can kind of see different signs and symptoms. Increased resistance to blood flow through the liver leads to portal hypertension and blood backs up. And then you're going to see these different types of things. So we have to worry about esophageal varices. We can have intrarectal varices, ascites, edema. So you can kind of just print this out and use this if you want. It is really important to know, at minimum, the different signs and symptoms and interventions that things are getting worse and things to watch for. Esophageal varices, if they hemorrhage, are life-threatening. So it's kind of important that we know we need to watch for these things with patients that have liver cirrhosis. So I really love these charts. I think they're very nice to give a good overview. All right, statistics. So we talked about Lanier's cirrhosis occurs in 30 to 50% of patients. Biliary cirrhosis occurs in 15 to 20% of patients. Post-necrotic cirrhosis occurs in 10 to 30% of patients. Pigment cirrhosis occurs in 5 to 10% of patients. And idiopathic cirrhosis occurs in 10% of patients. So the different causes of cirrhosis. So excessive alcohol consumption leads to cirrhosis and liver damage. And this is typically if there is chronic alcohol consumption injury or prolonged obstruction causes the biliary cirrhosis. Hepatitis causes that post-necrotic cirrhosis. Other diseases such as hemochromatosis causes pigment cirrhosis, and right-sided heart failure causes cardiac cirrhosis. So clinical manifestations, these are signs and symptoms that we are going to look for as the nurse. GI symptoms, early indicators usually involve gastrointestinal signs and symptoms such as anorexia, ingestion, nausea, vomiting, constipation, or diarrhea. We can also see respiratory signs and symptoms, but this usually occurs later as a result of hepatic insufficiency and portal hypertension, such as pleural effusion or limited thoracic expansion due to abdominal ascites, which will interfere with the gas exchange and lead to hypoxia. We can see central nervous system signs. This can be due to hepatic encephalopathy. This is a late sign, and you will see lethargy, mental status change, slurred speech, flapping tremors called asterisks, peripheral neuritis, paranoia, hallucinations, and ultimately it can lead to a coma. Hematologically, they may have anemia or have bleeding tendencies. Male patients experience testicular atrophies, so this is the endocrine system, while female patients may have menstrual irregularities. We can also see gynecomastia and loss of chest hair. Skin, there are usually severe pruritus, extreme dryness, poor tissue to normal pigmentation, spider veins, palmar edema, and possible jaundice. And hepatic, so we can see cirrhosis causes jaundice, ascites, hepatomegaly, edema of the legs, hepatic encephalopathy, and hepatic renal syndrome. So lots and lots of signs and symptoms with this illness. So these are some complications that we need to keep in mind as the nurse. So portal hypertension, so this elevates the blood pressure in the portal vein that occurs when blood flows because of increased resistance. Esophageal varices are dilated, tortuous veins in the submucosa of the lower esophagus. Hepatic encephalitis may manifest as deteriorating mental status and dementia, or physical signs such as abnormal involuntary movements, and fluid volume excess, which occurs due to an increased cardiac output and decreased peripheral vascular resistance. So as the nurse, these are some assessments and diagnostic findings we can use. So we can use a liver scan, which will show abnormal thickening and if there is a liver mass. We can do a liver biopsy. So this is a definitive test for cirrhosis as it detects destruction and fibrosis of the hepatic tissue. We can use liver imaging such as a CT scan, ultrasound, or MRI. And this can confirm the diagnosis of cirrhosis by visualizing the masses, abnormal growths, metastases, and venous malformations. We can look at cholecystography or cholangiography. These two visualize the gallbladder and biliary ducts. Splenoportal venography, which will visualize the portal venous system. Percutaneous transhepatic choreography, and this test differentiates intrahepatic from extrahepatic obstructions, jaundice, and dislodged hepatic pathology in the presence of gallstones. And we can also look at a CBC to see if there is a decreased white blood cell count, hemoglobin level, hematocrit, albumin, and platelets. So the medical management for these patients include diet. The patient may benefit from a high calorie and medium to high protein diet, as developing hepatic encephalopathy mandates restricted protein intake. Sodium restriction is usually restricted to 2 grams a day. Fluid restriction is usually restricted to 1 to 1.5 liters a day. Activity is usually to rest or have moderate exercise. We may use paracentesis, which can help to alleviate ascites. And we may use a Sangstakin, Blakemore, or Minnesota tube. And these help to control hemorrhaging by applying pressure to the bleeding site. Pharmacological therapy, we can use octreotide, which may be prescribed for esophageal varices. We can use diuretics, which can help with edema. However, we need to monitor them carefully for fluid and electrolyte imbalance because this can precipitate hepatic encephalopathy. Dose, which is what we use to treat encephalopathy. Well, hepatic encephalopathy. Antibiotics are used to decrease intestinal bacteria and reduce ammonia production, which is one of the causes of encephalopathy. So surgical management, so transjugular intrahepatic portosystematic stent procedure. It's also called TIPS, which is much easier to say. And this is the treatment for varices by upper endoscopy, and it helps to relieve portal hypertension. And this is just a picture of it, so you can see it right there, that it's connecting the portal vein and the hepatic vein. So nursing management. So for patients with cirrhosis of the liver, it should focus on promoting rest, improving nutritional status, providing skincare, reducing risk of injury, and monitoring and managing complications. Our nursing assessment, we should be monitored for bleeding. We should be checking the patient's skin, gums, stool, and if they're vomiting, check their vomit for blood. Fluid retention, so assessing the patient's weight, measure their abdominal girth at least once a day, and their mental status, assess their level of consciousness, and observe closely for changes. These are just some examples of different nursing diagnoses that we may give to these patients. Activity intolerance related to fatigue, lethargy, malaise, imbalanced nutrition, less than body's requirements, and related to abdominal distension and discomfort and anorexia, impaired skin integrity related to pruritus, jaundice, and edema, high risk for injury related to altered clotting mechanisms and altered level of consciousness, disturbed body image related to changes in appearance, sexual dysfunction, and role function, chronic pain and discomfort related to enlarged liver and ascites, fluid volume excess related to ascites and edema formation, disturbed thought process, and potential for mental deterioration related to abnormal liver functions and increased serum ammonia levels, an ineffective breathing pattern related to ascites and restriction of thoracic excursion secondary to ascites, abnormal distension and fluid in the thoracic cavity. So our nursing care planning and goals. So these are just some examples. So report decreases in fatigue and increased ability to participate in activities, maintain positive nitrogen balance, no further loss of muscle mass, and meet nutritional requirements, decrease potential for pressure ulcer development and breaks in skin integrity, reduce risk of injury, verbalize feelings consistent with improvement of body image and self-esteem, increase level of comfort, restore normal fluid volume, improve mental status, maintain safety and ability to cope with cognitive and behavioral changes, and improve respiratory status. All right, so now let's look at the nursing interventions for patients with liver cirrhosis. So first, we want to promote rest. To do this, we can look at positioning the bed for maximum respiratory efficiency, providing oxygen if needed, initiate efforts to prevent respiratory, circulatory, and vascular disturbances, and encourage patients to increase activity gradually and plan rest with activities and mild exercise. We also want to look at improving nutritional status, so we will provide a nutritious, high-protein diet supplemented by B-complex vitamins and other vitamins including A, C, and K. We'll encourage patients to eat, provide small, frequent meals, consider patient preferences, and provide protein supplements if indicated. We will provide nutrients by feeding tube or total PN if needed. We'll provide patients who have fatty stools with water-soluble forms of fat-soluble A, D, and E vitamins and give folic acid and iron to prevent anemia. and will provide a low protein diet temporarily if the patient shows signs of impending or advanced coma. Will restrict sodium as needed. So that is an important probably question that you'll see on an exam, is that the low protein diet is for when there is a change in mental status. So they're not on a low protein diet all the time. So we're going to provide them skincare. We're going to change the patient's position frequently. We're going to avoid using irritating soaps and adhesive tape. We're going to provide lotion to soothe irritated skin and take measures to prevent patient from scratching the skin. We also want to reduce the risk of injury, so we will use padded side rails if the patient becomes agitated and restless. We'll orient to time, place, and procedure to minimize agitation. We'll instruct patients to ask for assistance to get out of bed. We'll carefully evaluate any injury because of the possibility of internal bleeding. We'll provide safe measures to prevent injury or cuts, and we'll apply pressure to venipuncture sites to minimize bleeding. So as the nurse, we're also going to monitor and manage complications. So we'll monitor for the bleeding and hemorrhaging. We'll monitor their mental status and report any changes so that the treatment for encephalopathy can be initiated promptly. We'll carefully monitor their electrolyte levels and correct if abnormal. We'll administer oxygen if they are desatting. We'll monitor for fever or abdominal pain or any signs of an onset of a bacterial peritonitis or other infection. We'll assess cardiovascular and respiratory status, administering diuretics, implementing fluid restrictions, and enhancing patient position if needed. We'll monitor intake and output, daily weight changes, changes in abdominal girth, and edema formation. And we'll monitor for nocturia and later for algeria because these states indicate increasing severity of liver dysfunction. So home management, when we're preparing these patients for discharge, we need to educate them on their dietary instructions, including the exclusion of alcohol. They may need to be referred to Alcohol Anonymous, psychiatric care counseling, or a spiritual advisor. We'll continue sodium restriction, stress avoidance of raw shellfish. We'll provide written instructions, teaching, support, and reinforcement to the patient and family. And we'll encourage rest and probably a change of lifestyle. We'll instruct patients about symptoms of impending encephalopathy and possibility of bleeding tendencies and infection. We'll offer support and encouragement to the patient and provide positive feedback with the patient's experience success. And we'll refer patient to home care nurse and assist and transition from hospital to home. So these are some evaluations for our nursing interventions related to our nursing diagnosis. And these are just some examples. Again, this is going to be based on your patient and what actually happened or occurring to your nursing intervention. Here are just some examples. Report decrease in fatigue and increased ability to participate in activities. Maintained a positive nitrogen balance, no further loss of muscle mass, and meets nutritional requirements. Decreased potential for pressure ulcer development and breaks in skin integrity. Reduce the risk of injury, verbalize feelings consistent with improvement of body image and self-esteem, increased level of comfort, restored normal fluid volume, improved mental status, maintained safety and ability to cope with cognitive behavioral change, and improved respiratory status. And again, these are just some points for the discharge and home care. We want to restrict alcohol. We're going to restrict sodium, and we're going to let them know about different complications that they need to look for, the signs and symptoms for those. And this will be our documentation. So we want to make sure that we document on level of activity, causative and precipitating factors, vital signs before, during, and following activity, the plan of care, response to the interventions, teaching, and actions performed, the teaching plan, changes to the plan of care, attainment or progress towards desired outcomes, calorie intake, individual culture or religious restrictions, personal preferences, availability and use of resources, duration of the problem, perception in pain, effects on lifestyle, and expectations of therapeutic regimen, and results of laboratory tests, diagnostic studies, and mental and cognitive evaluation. So that is it for the liver cirrhosis video. If you guys like this video, make sure to give it a thumbs up and subscribe to the channel. And make sure to check out those free resources down below, as well as the NCLEX study guide. I hope you guys find this helpful, and I'll see you next time. Bye.